So, good morning. Coming to today's presentation on mouth breathing habit. Oral habits may be a part of normal development. Boucher OC has defined habit as a tendency towards an act or an act that has become a repeated performance, relatively fixed, consistent, easy to perform, and almost automatic. It can also be defined as a fixed or constant practice established by frequent repetition. Butterworth has defined as a frequent or constant practice or acquired tendency which has been fixed by frequent repetition. According to Matheson, these are learned patterns of muscular contractions. James has classified the habits to useful and harmful. Finn has classified them to compulsive and non-compulsive. Meaningful and empty habits was a classification given by Klein in 1971. And the new classification by Morris and Bohanna has divided the oral habits into non-pressure habits, pressure habits, postural habits, and miscellaneous. And under non-pressure habits comes mouth breathing. Mouth breathing has been defined by Sassouni as a habitual respiration through the mouth instead of nose. It has also been defined as a prolonged or continued exposure of the tissues of anterior areas of mouth to the drying effects of inspired air. Finn has classified mouth breathing in 1987 into three types: obstructive, anatomic, and habitual. Obstructive means there is increased resistance to or complete obstruction of normal airflow through nasal passage. Habitual means it's a matter of habit or persistence of the habit even after the elimination of the obstructive cause. Anatomical refers to the condition where there are short upper lips, which lead to incompetence of lips and thereby the habit that is the mouth breathing. Now coming to the etiology. It includes nasal obstruction due to either enlarged turbinates, deviated nasal septum, allergic rhinitis, nasal polyps, enlarged adenoids, chronic inflammation of nasal mucosa, abnormally short upper lip, obstruction of bronchial tree of larynx, obstructive sleep apnea syndrome, genetically predisposed individuals where the children may be having a genetic type of tapering face, and other oral habits including thumb sucking would be an instigating factor or a provocating factor for the mouth breathing. So in general, we can say that the developmental and morphologic abnormalities like the abnormal development of nasal cavity, nasal turbinates, partial obstruction due to deviated nasal septum, inflammation or infection of the nasal mucosa, allergic rhinitis or enlarged adenoids, like including conditions like adenotonsillar hypertrophy, localized even benign tumors, and the genetic pattern are the major etiology factors behind. Now coming to the clinical features. Generally, we can see that there are features like pigeon chest, low-grade esophagitis, then the variation in blood gas constituents, along with effect on various dentofacial structures. Like the facial form may include a large facial height, increased mandibular plane angle with retronatic mandible and maxilla. Adenoid fascia is characterized by long, narrow face, narrow nose and nasal passage, flaccid lips with upper lip being short, dolichocephalic skeletal pattern with nose being tipped superiorly, expressionless face with face-shaped maxillary arch and high palatal vault. So these features could be summarized as: in order to breathe, the child may be bending the neck forward in order to straighten the oronasopharyngeal path, giving the appearance of a pigeon chest. In mouth breathers, the oropharynx being very dry and can produce a low-grade esophagitis. Maxillary sinus and nasal cavity frequently becoming narrowed, with terminates becoming swollen and engorged. Speech acquiring nasal tone, and sleep apnea syndrome due to the loss of cleansing action of saliva, resulting in enlargement of lingual tones at the base of the tongue, leading to a partial or complete obstruction of oropharynx during sleep. And the blood gas constituents, as we are always seeing variations, showing 20% more carbon dioxide and less oxygen in the case of mouth breathers. In addition to these factors, you can also see adenophages, which is a characteristic feature with lips being held apart. Then a lack of tone of oral musculature, upper lip being short, chin being receded, face having a typical phagic face appearance, nose being tipped superiorly, long narrow face, expressionless face, and flat nasal bridge. Coming to the dental effects. This include upper and lower incisors being retroclined with posterior crossbite, anterior open bite, narrow palatal and cranial bit, tearing of incisors and decrease in vertical overlap of anterior teeth, along with speech defects with nasal tone in voice, short, thick, incomplete upper lip, with voluminous curled over lip, over the lower lip, and with gummy smile. Then we slit like external nails with narrow nose due to atrophy of the lateral cartilage. And gingival effects like there may be inflamed gingival mucosa with irritated gingival tissue in the anterior maxillary arch, giving the classic anterior margin gingivitis appearance, and with classic rolled margin gingiva and enlarged intended papilla with interproximal bone loss that presents of teeth pockets. Other effects include otitis media, dull sense of smell, and loss of taste. So, in general, we can sum up these dental skeletal features as long tongue position, narrow maxillary area, protrusion of maxillary and mandibular incisors, palatal wall being high, mandibular region is hanging open in a slack manner with anterior open bite, increased incidence of caries, mucus and plaque becoming more tenacious, along with chronic keratinized marginal gingivitis. Now, coming to the diagnosis part. We have to look for the history, clinical examination part where we're looking for lip incompetency, size and shape of external nails, clinical tests, including the mirror test, butterfly test, and water test. To explain them in detail, first you have to observe the patient where the nasal breathers will be having the lips being in a touching position, whereas in mouth breathers, the lips will be apart. You can ask the patient to take a deep breath through the nose where the nasal breathers will demonstrate good control of alar muscles where the mouth breathers will be showing no change or shape in the external nares. You can do the mirror test where it's also referred to as fork test. You're using a two-surface mirror. It is just placed on the patient's upper lip. If you see the air condensing on the upper side of the mirror, the patient is a nasal breather, and if it does not, like if it is doing so in the opposite side, then he's a mouth breather. Then you have the water holding test given by Masler, where the patient is asked to hold the mouthful of water for at least a period of 3 minutes, and mouth breathers won't be able to retain the water for a long time. And then comes the butterfly test, was given by Juman, where you are taking a few fibers of cotton, placing it just below the nasal opening. On exhalation, the fibers of the cotton flutter downwards, patient is a nasal breather, and fibers fluttering upwards is a mouth breather. And then you have the rhinomanometry or inner-tube plethysmography, where the total airflow through the nose and mouth can be quantified using inductive plethysmography. And also you have cephalometrics, which can be used to calculate the amount of nasopharyngeal space. Now, coming to the management of mouth breathing. Management of mouth breathing in children that involves a multidisciplinary approach. It includes dentists, pediatricians, ENT specialists, speech therapists, and orthodontists. The treatment is mainly focusing on eliminating the underlying cause, improving nasal breathing, and correcting associated dental and skeletal changes. There's first of all, you have to identify and you have to initiate the habit breaking therapy. Like the first step includes parental education and early intervention, where the parent should be informed about the effects of mouth breathing on dental and facial development. Encourage nasal breathing and closed mouth posture during daily activities, proper maintenance of proper sleep hygiene, especially in children with sleep disorder breathing. And then comes the myofunctional therapy, where there are exercises that can strengthen the oral facial muscles and retrain the nasal breathing, help restore proper tongue posture, lip seal, and swallowing patterns. Like myofunctional exercises usually include lip closure exercises, where the child holds a button between the lips and keeps them locked for 30 seconds, and that will help the strengthening of orbicularis oris muscle. And also there is tongue positioning exercise, where the child is trained to place the tongue against the palate and hold it for another 5 seconds. It can encourage proper palatal development, and also straw breathing and balloon blowing. All these help to improve the nasal flow, is airflow as well as orificial muscle coordination. And then there are habit-breaking appliances used when myofunction therapy alone is not effective. Like these appliances guide the child towards nasal breathing by making mouth breathing uncomfortable. Like common appliances and mouth breathers, you can make use of oral shield, which will prevent the habitual mouth opening, promoting nasal breathing. And you have appliances like oral screen, which is the most effective way to re-establish the nasal breathing, which is to prevent air from entering the oral cavity. Uh, like oral screen should be considered a material which is much compatible with the oral tissues, which helps in the reduction of eye drop and bite, usually for treatment for nearly 3 to 6 months. Like oral screen is a simple, removable, myofunctional appliance that is used to correct the not only the mouth breathing habit, but also the tongue tossing and lip incompetence in children. Basically, the design consists of a soft acrylic or silicone that consists of a shield-like plate that which covers the anterior teeth and lips. There may be small holes for air passage. This is optional. It is depending on the child's nasal breathing ability. We'll have the side extensions or loops will help retain the appliance in position. Like this appliance can help in multiple ways. Like it can encourage nasal breathing by blocking the oral airway, that which force a child to breathe through the nose, can strengthen the orofacial muscles, like promoting lip competence by activating the orbicularis oris muscle, and can even encourage proper tongue position or tongue posture against the palate. It will prevent the malocclusion progression, like reduces the proclination of upper incisors due to mouth breathing. It can help correction of andropen by caused by tongue thrusting also. That is, it will be reducing tongue thrusting habit also by acting as a physical barrier. It will prevent the tongue from pushing against the teeth. So the indications usually include mouth breathing habit, lip incompetence, tongue thrusting habit, speech articulation defects, as well as mild to moderate dental malocclusion. But the contraindications, usually it is not indicated in case where there's severe nasal obstruction or there is fixed orthodontic appliances already is kept in place, as well as severe skeletal malocclusion, which requires actually orthopedic or surgical correction, or even in case of uncooperative children, which where you may find reduced compliance to wear the removable appliance. The different types of oral screen include passive oral screen, which is a simple screen that passively prevents mouth breathing, or there is active oral screen, which includes lip exercises to strengthen the perioral muscles. This is an oral screen with air holes, which allows partial oral breathing in children with nasal obstruction, as well as modified respiration springs, used in cases requiring additional orthodontic correction. Regarding the instructions for use, it should be worn for a few hours daily, especially during rest period, can be used during sleep time for better compliance. Regular cleaning is mandatory, but there is a need for follow-up, which is required every 4 to 6 weeks to assess the progress. And then you have the pre-orthodontic trainer. It's usually used in mouth breathers, tongue thrusters, and thumb suckers. It consists of lip bumpers, like which can encourage lip closure, strengthen the orbicularis oris muscle, tongue tag or repositioning device where can train the tongue to rest against the palate, thereby preventing the tongue thrusting. Even air vents, which are optional, allowing the partial oral breathing in case of mild nasal obstructions. You can even see two channels which can guide proper eruption and alignment of developing teeth, plus the flexible material, ensuring patient comfort while applying light forces for correction. So the mechanism of action include it can eliminate mouth breathing by forcing the lips to stay closed, promoting nasal breathing. It can correct the tongue posture by guiding the tongue to rest against palate, preventing tongue thrusting. It can encourage proper swallowing patterns, preventing abnormal tongue movements during swallowing. It can aid in dental alignment, guiding the erupting the teeth eruption to in proper positions, reducing crowding, and even improve oral facial muscle tone, strengthening lips, cheeks, and tongue muscles. Indications include mouth breathing habit, tongue thrusting habit, and lip incompetence situations. But here also we can see there are certain contraindications like cannot be given in cases where there is severe skeletal malocclusion, like skeletal class 3 cases, or severe nasal obstructions where there is adenotonsillar hypertrophy or levator nasal septum, or in case of non-compliant patients. Regarding the different types of pre-orthodontic trainers, you have myobrace trainer, which is the most commonly used, available in different sizes and shapes. Then you can have tree 4K trainer, which is designed for mixed dentition correction. You have infant trainer for young children targets the oral habit correction in early age, and even T4A trainer for permanent dentition, helping aligning teeth in teenage years. Regarding the usage instruction, wherefore nearly 1 to 2 hours daily and during sleep, breathe only through the nose while using the trainer. Perform myofunctional exercises recommended by the dentist, maintain good oral hygiene, clean the trainer regularly, follow up for every 6 weeks for proper assessment of the condition. Now, coming to the use of various mechanical appliances, um, you have oral shield appliances already been discussed for the correction of classroom maloclusion with anterior spacing, and you can even use monoblock or activated appliances or even a Frankel appliance for the correction of classroom division on malocclusion along with the mouth breathing habit. Like it's a functional appliance that trains the lips and orofacial musculature to close the mouth, working by removing abnormal oral muscle forces and promoting proper oral function. Such appliances like activator or Frankel appliance usually consist of buccal sheet and lip pads that which encourage proper tongue posture and nasal breathing, but can be used in the mixation stage also. So the typical indication include mouth breathing with lip incompetence associated with developing malocclusion due to soft tissue dysfunction. And then you have lip bumper appliance for lip, also not referred to as lip competence appliance, as a fixed appliance strengthened to muscles as well as encouraging lip closure, working by applying gentle pressure to the lips. And then you have the e-functional jaw orthopedic appliances, which include twin block appliance used in cases where mouth breathing has led to skeletal malocclusion, helping to correct jaw discrepancies while improving breathing patterns. And can even use twin block appliance, which guides the mandibular growth, airway function, and the bionate, which positions the tongue properly and encourage nasal breathing. Indication being skeletal discrepancies due to prolonged mouth breathing, as well as functional jaw correction in mixed or permanent dentition. In class 3 malocclusion cases, it can also be seen that the use of chin cup can correct the condition. And finally, after doing all this, you can also cannot neglect an adequate ENT evaluation and medical management, because in case of hypertrophic adenoids or tonsils that may require tonsillectomy if air obstruction is severe. Like in case of allergic rhinitis or sinusitis, antihistamines, nasal steroids, or saline sprays has to be prescribed for the congestion relief. And for the deviated nasal septum correction, severe cases may require a septoplasty to remove the nasal flow. I can also advise breathing therapy, nasal training. Like nasal strips could be used for open nasal passages and encouraging proper breathing. And there's a new breathing method, which is referred as Gutaiku breathing method, which involves controlled breathing exercises to train nasal breathing, and it's useful for the children with habitual mouth breathing due to nasal resistance. And for orthodontic and dental correction, you can have expansion therapy for narrow maxilla, where you can use expansion appliances like quad helix appliance or rapid maxillary expansion appliance, which helps to widen the constrictor approach and increase the nasal airway space, and also improve the tongue posture and prevent further malocclusion. That's all. Thank you.